Good morning, everyone. Welcome to Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, and we are discussing this amazing series on NEET SS previous year's topics. So today we are discussing the important topic of Okay, today we will discuss very important topic in pediatric nephrology, that is renal tubular acidosis. This is important entity and it is actually commonly encountered in OPD settings, also in ICU settings. It is very prevalent than thought of. Okay, so we'll start with renal tubular acidosis, a disorder of non-anion gap metabolic acidosis. Just pay attention on the keyword non-anion gap metabolic acidosis, normal or near normal GFR, and due to impaired renal acid excretion or defective bicarbonate reabsorption. Basically, what it is, the common or highlighted features are NAGMA, non-anion gap metabolic acidosis, and normal GFR is the hallmark of RTA, renal tubular acidosis. How this occur, what are the mechanisms including acid secretion and bicarbonate absorption problem, we will discuss them later, but as of now just remember the hallmark of this condition is NAGMA. This is non-anion gap metabolic acidosis with normal GFR. Okay, so this is overview of renal tubular acidosis. How this occur? Before this slide we'll discuss how normal urine acidification occur. Okay, so just remember how normal urine acidification occurs. So in this condition, renal system maintain acid-base homeostasis. How kidney maintain acid-base homeostasis? Mainly these are two mechanisms: reabsorption of filtered bicarbonate and hydrogen ion secretion. Basically, kidney wants to reabsorb bicarbonate and excess hydrogen ion gets secreted. Okay, so reabsorption of filtered bicarbonate, where it occur, 90% occur in proximal tubule and 10% of bicarbonate reabsorption occurs in distal tubule and collecting duct. So this is the filtration or reabsorption mechanism of bicarbonate. Put hydrogen ion secretion. Key sites are proximal tubules, thick ascending limbs, and collecting tubules. It is secreted via how this hydrogen ion H plus is secreted in proximal tubule. It is secreted via sodium H plus exchanger, and in collecting duct it is secreted via H plus ATPase pump. Okay, many buffer are there which manage these conditions, and aldosterone stimulates H plus ATPase activity. So as of now, just remember bicarb reabsorption where it get reabsorbed, and H plus secretion where it get secreted in proximal and distal tubule, which are the ions exchangers. Just see this beautiful image. Don't get overwhelmed by this information in this slide. Just see, this is proximal tubule cells, this is collecting tubule cells. Okay, what we'll see in this, in these two images, the main focus will be on bicarbonate. Okay, so bicarbonate in proximal tubule is formed, which is actually H2O. It is getting divided into H plus and OH ion. OH ion is combined with CO2 in presence of carbonic anhydrase 2, and bicarbonate is formed. This bicarbonate actually go through sodium bicarbonate symporter to systemic circulation. This is 90% way of bicarbonate absorption. So you understood how bicarbonate form. Bicarbonate forms via H2O. H2 gets break down in H plus and OH negative. OH negative combines with CO2 in presence of carbonic anhydrase 2 and carbonic HCO3 bicarbonate form. This bicarbonate gets and go into systemic circulation via this sodium bicarbonate exchanger. Okay, so this is the common phenomena in proximal tubule cells. What happened to this H plus which is there? It gets secreted into the lumen via sodium H plus exchanger. So this is important mechanism. Now we'll go to collecting tubule cells. What happen in collecting tubule cell? Just see, same H2 it is getting divided into H plus and OH negative. OH negative similarly combines to CO2 in presence of carbonic anhydrase 2 and bicarbonate is formed. Now this goes to systemic circulation via bicarbonate chloride exchanger. It is actually less common. This is 10% cases. This is get absorbed. So bicarbonate absorption we have seen via proximal tubule and collecting tubule duct. Okay, now the remaining H plus. H plus is secreted by H plus ATPase pump into the lumen. Okay, into the lumen H plus is there, remaining HCO3 is there, they form H2CO3, bicarbonic anhydrase 4 they get divided into H2 and CO2 and they get reabsorbed. So by this image, just remember these keyword bicarbonate is in relation with PCT and H plus in relation to DCT. Okay, so any problem in proximal tubule cells in absorption of bicarbonate leading to proximal RTA, also called as type 2 RTA. So just remember, any problem in acid secretion leading to distal RTA, and this is type 1. Remember, distal RTA is called as type 1. So this is type 1 and type 2 RTA, proximal and distal RTA. Okay, with this important background knowledge, we'll go to this beautiful slide which explains everything and summarize the RTA. Okay, just go with me. Distal RTA we have seen it is called as type 1 RTA. We have seen and in that image in distal RTA impaired H plus secretion in distal tubules, which is the main primary defect. So if H plus is not getting secreted, urine will be basic. So the pathophysiology is generally uh, regarding to this H plus secretion and basic understanding must be required. Okay, so urine pH remains more than 6 as understood. Hypokalemia, potassium is lost along with H plus. Okay, potassium is lost, H plus is not lost, sorry. Hypercalciuria leading to nephrocalcinosis and kidney stones. Just remember, this is very important. Type 1 or distal RTA is associated with hypercalciuria and kidney stone formation. Similarly, clinical features are growth failure, metabolic acidosis, nephrocalcinosis, and bone disease. Type 2 or proximal RTA, as we discussed in earlier also, type 2 is defective bicarbonate reabsorption in proximal tubules. So urinary pH initially may be high but less than 5.5 is the hallmark feature. You can see bicarbonate wasting is there associated with Fanconi syndrome. Symptoms are same as type 1 or distal RTA except nephrocalcinosis and kidney stones are not found. Type 3 is mixed, so mixed feature will be seen, we will not discuss it. Type 4 again is very important, hyperkalemic RTA. Which RTA is hyperkalemic? That is type 4. It is due to aldosterone deficiency or resistance due to leading to impaired sodium reabsorption H plus K plus secretion. This leading to hyperkalemia and growth retardation, urinary pH is variable. So this is beautiful description of RTA types. Just go through this normal urine acidification process once through these slides and just go through this diagram once again. This will explain everything about pathophysiology about renal tubular acidosis. Okay, So this is actually, these are causes of proximal renal tubular acidosis and distal renal tubular acidosis. There are plethora of lists like primary and genetic variants. Many drugs can cause. Okay, genetically transmitted syndromes associated with Fanconi syndromes can do. Dysproteinemic states, secondary hyperparathyroidism, drugs, tubulointestinal disease. Similarly, for distal tubal renal acidosis, familial causes are there, autoimmune causes are there, hypercalciuria, nephrocalcinosis are there, drugs, tubular interstitial disease are there. There is plethora of list. Don't mug up this list. Just understand the basic important diseases leading to RTA. We'll discuss them later. Okay, now we have understood the basic differences. Just it is description of that physiology and table we have discussed earlier. So it will be easy for you to grab in a more spread manner. Okay, so type 1 distal RTA we see. So what is the pathophysiology? Again we discussed it. Defective H plus secretion distal tubule, inability to acidify. Urine pH will be more than 6. Hypokalemia will be there, and this is important feature, hypercalciuria, nephrocalcinosis and kidney stones. Okay, what are the causes? So it may be genetic causes as we discussed in the table also. Secondary causes like acquired distal RTA, autoimmune disease like Sjogren's syndrome, lupus, amphotericin B, NSAIDs in drugs, chronic kidney disease and other disease can contribute. So what will be the clinical features of distal RTA? Growth failure in children, polyuria dehydration, metabolic bone diseases, nephrocalcinosis and kidney stones will be there. Okay. And again, important thing, urinary pH will be more than 6. We are discussing it. Basic urinary pH will be there. Low serum bicarbonate levels and hypokalemia nephrocalcinosis on renal ultrasound. We have discussed it earlier. Type 2 proximal RTA, again defective bicarb reabsorption in proximal tubule leading to less than 5.5 urine pH. Okay, many causes are there, but they are mostly associated with Fanconi syndrome. Causes are cystinosis, Lowy syndrome, Wilson disease, drugs like ephosomite toxicity, vitamin D deficiency. Clinical features are same along with phosphate wasting and rickets. But just remember, in this proximal or type 2 RTA, nephrocalcinosis or kidney stones will be not found. Diagnosis, you'll see urine pH is less than 5.5, low serum bicarbonate, features of Fanconi syndrome. What are the features of Fanconi syndrome? Glycosuria, phosphaturia, amino aciduria. It means in urine the glucose will be low, so hypoglycemia will be seen, phosphate will be lost, and amino aciduria will be seen. Okay, type 4 in hyperkalemic RTA, it is due to, this is important, aldosterone deficiency or resistance. So how aldosterone deficiency in Addison disease, congenital adrenal hyperplasia, aldosterone resistance in obstructive uropathy and chronic kidney disease. They leading to impaired potassium excretion. If potassium excretion is impaired, hyperkalemia, which is generally life-threatening hyperkalemia, inhibits aminogenesis and it reduces acid excretion. Okay, so many medications like NSAIDs, ACE inhibitors, and heparin produce this type 4 hyperkalemia. Metabolic acidosis will be mild, but hyperkalemia again we are emphasizing it again and again. This will be more. So hyperkalemic non-gap metabolic acidosis, low renin aldosterone levels will be seen. Okay, now I discussed all these RTA. Just pay attention, keep your attention here. How you will diagnose? Just simplified approach. Just see if it is NAGMA. You found a metabolic acidosis patient. See if it is NAGMA. All you know how NAGMA is calculated. Serum anion gap, sodium minus chloride plus HCO3. If it is less than 12, it is normal anion gap metabolic acidosis. If it is more than 12, then renal tubular acidosis is ruled out. Next step, just see serum potassium levels. If potassium levels are high, it is definitely due to type 4 RTA. If it is low, it may be due to type 1 or type 2. Urinary pH. If pH is more than 6, it is definitely due to type 1 or distal RTA. Less than 5.5, it may be due to 2 and 4. Another important thing, just remember, urinary anion gap is positive in distal RTA and negative in proximal RTA. This point has been tested in AIMS exam. So urinary anion gap is positive in distal RTA, negative in proximal RTA. Obviously, when you will do renal ultrasound, nephrocalcinosis is seen in type 1 RTA and obstructive uropathy like features will be seen in type 4 RTA. Okay, so this is again a table from Nelson explaining all features of these conditions. We have discussed them. Just to revise. Potassium, we discussed it. Potassium will be high in this type 4 generalized distal dysfunction. It is also called as type 4. So type 4, the potassium will be high. Other thing, potassium will be low. Urinary pH, we discussed it. In distal RTA, the pH will be more than 5.5, or you can say more than 6. In other condition, it will be low. Urinary net charge or urinary anion gap we discussed in type 2 RTA, type distal RTA, type 1 RTA, it is positive, and sometime in type 4 RTA it is positive, but classically urine anion gap is positive in distal or type 1 RTA. Fractional bicarb excretion. So just see, in proximal tubules, the problem is in bicarbonate reabsorption. So maximum bicarbonate is lost in this condition, 10 to 15% in proximal condition. UBP CO2, this is actually urine minus blood CO2 pressure. So this is not routinely performed. This is experimental thing. But just remember, in proximal RTA, it is normal, and other RTA, it is low. Res Associated features are Fanconi syndrome in proximal RTA and nephrocalcinosis, hyperglobinemia in distal RTA, and renal insufficiency in type 4 RTA. So in this table, just remember 3-4 things about potassium. Potassium is high in type 4 RTA. Urinary pH is high in type 2 RTA. Urinary net charge is positive in type 2 RTA. Urine minus blood CO2 pressure is normal in proximal RTA. Other thing is low, and associated features are Fanconi syndrome, nephrocalcinosis, hyperglobinemia, and renal insufficiency. These are important. Okay. So how you will treat? So just pay attention. Type 1, that is distal RTA. What is the problem? Impaired H plus ion excretion. H plus ion is not getting excreted. Okay, so bicarb is getting lost but in less quantity. So give sodium bicarb 2 to 4 millicurie per kg per day in maintenance dose. Along with hypokalemia is there, so give potassium supplements, and just check, this is important, just check urine routine. If urinary calcium is positive or urinary calcium is getting lost, hypercalciuria is there, just treat with thiazide diuretics. So important concept, thiazide diuretics are used in distal RTA in case of hypercalciuria, very much important. Type 2 proximal RTA. So see, in this type of RTA, the main problem is a reabsorption problem of bicarbonate. Means bicarbonate not getting reabsorbed, bicarbonate is getting lost. So give large dose of bicarbonate. How large? Just remember 10 to 20 milliequivalent per kg per day. And phosphate supplementation you have to give. Phosphate supplementation you have to give if Fanconi syndrome is there. This is very much important. Okay. Type 4 hyperkalemic RTA. So this RTA in this condition, fludrocortisone, loop diuretics and sodium bicarbonate are seen. So what are the key takeaway? RTA causes non-NN-cap metabolic acidosis with normal GFR. Urinary pH helps differentiating these proximal and distal RTA. So this is very important topic. This was all about RTA. It is very important practice point of view and ICU settings and exam point of view. Just go through this important brief discussion of RTA and trust me, you will get all clarity from RTA point of view. Euconium Elias. We'll discuss some another topic of this amazing series. Till then, do share, like, and